Welcome. The CGH Foundation is pleased to welcome you to our third presentation regarding the legal, financial, and care planning aspects of the dementia journey. We're see some familiar faces and see some new faces here. My name is Sam Meyer. I'm a foundation trustee, and I'll be hosting tonight. We have a wonderful panel with us here today to give you some information. I will introduce them here momentarily. I did want to make a couple of housekeeping notes. Everyone should have been able to receive a purple bag with some information in it on their way in. If you did not get one, we have plenty out there in the back yet, so please make sure you pick that up. There should also be some information at your table that our speakers will be referencing tonight. Bathrooms are out in the main foyer in the community room if you need to use the restroom. And so the foundation has dedicated this year to raising awareness to dementia and to providing new and expanded resources for area families. Our new dementia project was sparked most recently from an area family, a bequest from Hugh and Betty Miller of Rock Falls. Betty battled dementia for 11 years before passing away in 2020. And it was Hugh's wish last year before his death that the foundation would develop a new dementia program to make it easier for families and caregivers to help their loved ones. So that's why we're here tonight. And tonight's program is called Options for Care. In our previous sessions, which are available on YouTube and you can see at your convenience, we discussed some of the basics regarding dementia and how it affects area families. We also talked about some of the financial aspects and legal aspects. Tonight we're going to focus more on the care planning itself. And as I alluded to earlier, we have a wonderful group of speakers. Our featured speaker tonight, and as I say your name, guys, if you do me a favor, just kind of wave a little bit at the crowd. But our featured speaker tonight is CGH primary care physician, Dr. Eric Coons. He will speak, his presentation is entitled Caring for the Patient with Memory Loss at Home, at the Doctor's Office, and at the Hospital. And then in addition, we'll hear from 8 other panelists who can speak about the care planning and resources available. They include Mark and Margaret Zumdahl, an area family. Mark and Margaret have been on a dementia journey since 2016 when Margaret was diagnosed with Alzheimer's. So they're going to share their experience. As an aside, I mentioned this the first time they were here, but they were some of the first people I met when I moved to the area nearly 15 years ago, so time certainly flies. Also, we have with us tonight Denise Wooden. Denise is the director of CGH Home Nursing in Sterling. Carla Byrne is the marketing director, specialist the marketing director at Rest Day Care and Rehabilitation in Morrison. Wendy Eckel. Wendy is a community resource specialist at the Whiteside County Senior Center. Kristen Fager. Kristen is the care coordinator at Lifescape Services in Rock Falls. Jamie Long. Jamie is the founder, CEO, and benefit advocate for Golder Care Solutions in Moline. And Hadi Finnerty is the senior manager of education and community volunteer for the Alzheimer's Association. She's out of Plainville. So they're going to talk about such topics as home care, independent living assistance, assisted living, skilled and long-term care, memory care, and dementia-related services in the area. We're going to talk a little bit about costs and living with dementia. So without further ado, I'm going to introduce Dr. Coons. Dr. Coons has been practicing in Sterling since 2001. He received his bachelor's and doctor of medicine degrees from Loyola University and completed his residency at Hinsdale Family Medicine, where he was chief resident. He is board certified in family practice, was chair of the CGH Department of Medicine from 2018 until this past month, and was a leader at CGH in educating the public about COVID and all its concerns since 2020. His mom, Betty, passed in 2020 from complications of COVID with dementia, and both in his practice and behalf of the CGH Foundation, he carries with him her example of searching for the best in every situation and hopes to be able to help others on their dementia journey. Quite the intro, Dr. Coons, a lot to live up to. So without further ado, Dr. Coons.
Well, thanks, and couple of background things. So you know, my experience is colored some, not only by my patient care. I've had a lot of patients over the 21 years I've been here with dementia, but also with the personal experience of having a mother have dementia. Her name is a little difficult. It's Beata Coens. That's all right. Common thing. And she was completely healthy with the exception of her dementia. She was super fit, very healthy, and we always joked that she would win the Alzheimer's Olympics because she was a runner, and not before, but in the during time, she became a runner, and she would scale fences at Morningside, and she was definitely a handful, and taught us a lot about all the resources we need to make that work. And everybody's dementia journey is different. I've had patients that have been very happy their whole time and have kind of regressed into a childlike state. I had talked with someone this morning about that sort of situation. My mother's was a little more difficult when she started going back to childhood. Some of that was during post-war Germany, her home country, where they would have Russian soldiers break in and kick them out of the house. So she got very fearful of things, and that affected her journey quite a bit. And we'll talk a little bit about that too. So that's some of where I'm coming from. Beata unfortunately passed away from complications related to COVID in 2020, but she certainly leaves quite a legacy for all this, and we remember the good days. So let's talk about some care tips, starting with the home. And this is something I can certainly relate to, creating a safe environment. That's really critical at home for people who are having some trouble with either wandering or sometimes turning stoves on, leaving stoves on, stuff like that. There's a wonderful world of child devices that can work pretty well for that, on doorknobs and things like that. What I find is it's much more helpful to make the environment safe than to try and nag someone with a dementia problem into doing the right thing, because it's not something that tends to get through, and it tends to cause severe debility there for sure. So engage a lot of that. Also, something to wear. I know for my mother, she was into shiny things, so when we tried to get her a regular wristband, that didn't work out. But when my lovely wife, Linda, who's in the back, figured out that a piece of jewelry engraved with some of the information went over much better. And so there's a lot of creativity involved in trying to figure out that sort of stuff. Also, speaking of creativity, a lot of times it's important to go into their world rather than trying to drag them into ours. And a few examples, my mother sometimes, as things got further along, wouldn't recognize she was at home, didn't want to get out of the car. So rather than trying to wrestle her out of the car, we would back out of the driveway and drive around the block and talk all about how we're almost home now, and isn't it pretty here, this house? And it would help her get oriented, and then we would pull in and she would get out and go in the house okay. But spending some time identifying with how they're feeling, you look stressed, letting them talk that out. And if it's not something that's important, just running with it, whatever it might be. If it's something that's dangerous or critical to the moment, you might have to redirect them. But sometimes it's easier just to kind of run with whatever they're doing and ask them to explain, or if it ties into something else that they remember or you remember, kind of run with that. One thing that's a big issue, and I saw it both in the wear and tear of my father and my sister in particular, who spent the most time 2 years at home caring for mom, is to get some support. And one good place is to look around here. There's a lot of people on a similar journey, and say hello to your neighbor, and compare stories, and maybe it's somebody you can call and ask how something was handled or how it went. There's also a good resource for that through the Alzheimer's Association. If you call the Alzheimer's Association, I think Joan has some information on that. You can get set up for about a 45-minute or so consultation with a master's trained person in Alzheimer's behavioral health, and they can often help with difficult, how do I deal with this circumstance? And they also have a crisis line, and I've had patients use that where they, their person with Alzheimer's was up at night and they didn't know how to handle a particular situation, and they called the crisis line and they talked them through that. So that can definitely be helpful. Think about protecting finances and plan early. I've had some people get into a lot of trouble with losing money through well-meaning stuff or not, scams as well. So be careful with that for sure. My mother was in the banking industry, so she thought she still had all that stuff, and it can definitely be an issue. I had a conversation with a patient yesterday who was their significant other was an inventor and knew a lot of very, very important people, and had all those phone numbers and would still call them and try and buy some very expensive stuff. So really think about being careful with that early on, because it may sneak up on you earlier than you think. So a good thing to plan on that way. As tempting as it is, don't try and argue or reason too hard with someone. And it's oftentimes you're married for 40 years. You could convince, you could prevail on your husband, your spouse, if you said these words. You knew that they were in trouble and they were going to listen now, right? That doesn't always work so well as this comes in. So try not to take it personally as well. A lot of the things that are said may not apply to you or really be meant towards you, even though they're being said by the person you love. And I've had spouses stand up in church and accuse their loved one of cheating on them in church, and that's an awkward situation. So always good to, if you feel at all comfortable, just to spread the word that, there may be some unusual things. Bear with us. We love them all the same, but we gotta run with this. I know with my mother, being very fit, sometimes she had comments about weight that got a little awkward in the restaurants. So it's everybody's journey is unique, but just roll with that the best you can. The cards that they have here are sometimes helpful too. They talk about that. So all things to help. And Linda, maybe you can help me out here. There is a little symbol that I'm forgetting that you pin on to give people, what was that? Did anybody else know? Maybe it needs to be better publicized to be useful. Linda will look it up for us, but this is something maybe we could make as a community thing to be better known too. Just a little symbol to say, hey, this person might need a little, what?
The sunflower, the Hidden Disabilities.
Okay. Thank you. Yeah. So that's something that might be helpful, and maybe we can kind of spread that in the community too, just so that people have some understanding and patience with that as well. Body language is important, especially as language goes. Sometimes that's the only the thing that can be picked up on. So even when you don't feel like it, smiling is really important. So try and keep up with that. Try and make sure you're allowing and encouraging the people to do whatever they can, because there's this temptation to always want to do stuff for somebody, especially somebody you love. But it's very important, both for their self-worth and also keeping them busy, that you have people do what they can. It may be sorting things. If they were a mechanic, maybe they're sorting sockets. Maybe, for my mother, she loved flowers, so we would get her flowers, and she would organize flowers quite a bit. And that sort of stuff is good. If they can fold laundry or whatever it is that's their special skill, be creative about keeping them involved and active, because it's really important for all of their well-being to do that. Try and resist the temptation to do things for them, but find a way that they can do them themselves as much as possible. Music is another good thing. And lastly, I can't emphasize this enough, for the caregivers, take care of yourself. I see that a lot where the people who have the dementia or sometimes other diseases, they're getting good care, they're getting taken care of. And it's the caregiver that falls apart and really struggles, because it's a long, lonely journey, and I hear it a lot that family members aren't always all that helpful from far away. They don't remember or they don't realize where mom or dad is at right now, and they just think, you don't have to work. All you're doing is staying at home and, watching mom. Well, that's not so easy. Yeah, and oftentimes that's taken for granted, and people are busy and they don't really want to help. It's okay to have that expectation that people share the load that way, and that you have some time on your own. Don't feel guilty for carving out some time, scheduling it every week, that you take care of yourself, you get some exercise, you spend some time with friends, you get out and do some things. To that end, there's some respite care available. I'm sure we can talk about that a little bit later. That is a good thing to do, and it's one way to explore a little bit about how things go with memory care options. For my mother, not so well. She only lasted a day and a half at Morningside before she scaled fences and was kicked out. But we learned something, So, yeah, she pushed benches up against there, and anyway, lots of stories, and but the important part is think about some time in respite care, and some of the support groups have respite care as a part of that, so you get to go to the support group and the patient gets respite care. All right, well, let me make sure I covered those things, and feel free to interrupt me or talk. I want this to be interactive. I'm sure you guys have some of your own questions and stories.
I'm going to turn on this mic here and grab that one back from you in case we do have some questions, and that way I can pass it around and see. But yeah, we're going to hear from many other speakers here tonight, but I think a wonderful opportunity if anybody has any broad questions they would like to ask Dr. Coons.
It should be on.
Okay. Can you hear me?
I'm sure he'd be happy to take them. I should note that also many of us will stick around later as well after the presentation if you have something perhaps you'd like to share more privately. But yeah, does anyone have any questions for Dr. Coons at all? I thought it was very, very interesting about some of those sensory issues that we're discussing.
I've got a few other brief topics to cover still, so I'm not quite done yet. I wanted to pause there at the, I'm kind of mostly done with the home environment. One of the next things is when do we think about, this is always a tough decision, when do we think about having somebody involved in the nursing home? It's often that the expectation is that the family member, we're just going to suck it up and take care of mom or dad at home no matter what, and nobody's putting my relative in a nursing home. Be careful with that until you live it, because it can sometimes be a really unrealistic expectation, and it's not even always the best. Some people are very social, and the social aspect is really critical, and they really do better, at least with some time. And other ones, maybe not so much, but there are times that it's just untenable. So when are the times that you start thinking about that, whether you decide to do it or not yet? One of the things is when things that involve danger start to happen. They're leaving on stoves, or making sparks in the microwave or stuff like that, and this starts happening a little bit more. And some of the things you can try and manage with the child lock, some of the things maybe not. My mother was very strong and was able to break child locks pretty well. So that can sometimes be an issue. But that's one time to think about it. If people are wandering, getting lost, all right, that's another time that safety becomes an issue, and you might want to start thinking about that. Another time is if there's a point, and I'm sorry this might be a little depressing sometimes, but where they don't recognize you anymore. Then, for my father, he was all in that it was, he married for better or for worse. He was all in. He was going to care for mom to the bitter end, no matter what. But what started happening is mom no longer recognized him as rich. But as we think, mom wasn't talking in ways we'd understand, but she at times would become very frightened when he came in and probably think that he's some sort of Russian soldier, to the point that we were really starting to worry about dad's safety. Again, remember mom's ninja skills were very impressive, and she could play a mean game of ping pong. She could talk to you, but she could play a mean game of ping pong all the way through the end, and we had to start worrying about knives and scissors and all that sort of stuff. And it got to the point where Dad wasn't always helpful for mom anymore, and that was very hard for him. But when she was in, she did find a place that could corral her a little bit and work with that. When Dad came in then, it was more novel, and she would do better recognizing him and have a good time. But if it was dark in the house and she was uncertain, then very quickly he would become this dangerous person. So that's another time that you think hard about saying, geez, maybe this is a time we ought to think about nursing homes. And then there's just this plain old, I can't do it anymore. And please don't think that that's unreasonable. This is a 24/7 thing that can become super debilitating and exhausting. So there are times that that's the case, and sometimes it's respite care, and sometimes it needs to be relatively permanent too. I know some of the other people are talking about nursing homes and what to look for, so I'm going to leave that most to them. I have a few things. When it comes to dementia, make sure that they have some at least memory care services. Some places have a memory care wing, some places have memory care rooms and services, but make sure that that's something that they're actively a part of, and they have nurses that know how to de-escalate these situations. That's a specific skill and takes some training to do, and some places are better than that than others. If you're struggling with a nursing home and you've tried to do all the right things within the system, sometimes the Catholic Charities Ombudsman is a good resource to turn to. They're good at kind of negotiating and helping resolve situations. Last thing, in the hospital. This sometimes comes up earlier than you would think. And sometimes it's our first idea that there's some trouble. Mom or dad end up in the hospital, and all of a sudden they're seeing things, or they're running away, or they're confused, and this has never happened before. But if you have someone who has some mild cognitive impairment or early signs of this, and you put them in an unfamiliar environment, you make them sleep deprived, you put them on some medications that may be a little bit confusing, that may come out for the first time. And sometimes the only way to make that entirely better is to take the leap and go home, and back in the normal environment, things will often get better. It can be a harbinger of problems to come, but be aware that putting somebody in the hospital is often a sentinel event, or can often make this worse because of all those different stressors that happen in the hospital. Oftentimes when that happens, better than medication is a familiar face. And now that we don't have so much in the way of COVID restrictions, really helpful if we can get a family member in there sometimes to sit with them, talk them down, work with them, rather than using medications. Because medications often can lead to more sedation, sometimes even more disorientation. They may help agitation, but not orientation, so to speak. And they can relate to falls and that sort of stuff. Okay, so I think with that, I have most of what I wanted to cover, but what do you guys have questions about, or thoughts? Joan?
When do you decide to come to see you? When do you make that
Yeah, we didn't
decision?
talk enough about maybe some of the office stuff too that way. So first and foremost, the first part of the evaluation for this is, for any sort of memory loss is very simple. It's, some basic memory testing in the office. It's some blood work. and we kind of talk through things from there. Sometimes it is just being sleep deprived or stressed or depressed. There's other things that can mimic early signs of, there's a lot of people who on a bad day think they're losing their mind, right? This has probably happened to all of us at some point. So I would have a very low threshold for coming in and seeing your primary care doctor if you're worried about that. I mean, we do this sort of stuff all the time, and sometimes it's reassuring. Sometimes you're just low on B12 and we need to fix that. It's easy, and other times we need to start the process of getting you involved with a neurologist and those sort of things. But yeah, feel free to do that early. It's really helpful if family members come in with the person, because oftentimes people in early stages, and especially people who are used to, they're very good at talking and public events or just smart people in general, they compensate very well. And in the limited scope of the things we deal with in an office visit, this doesn't really come up. But a family member can say, hey, we're starting to notice these sort of things, or they can help with what are some of the specific problems that we can offer specific tailored solutions for. How do you deal with this behavior, this problem? You notice I haven't talked a whole lot about medications. There are some out there. And there's a new one that's, again, looking hopeful. But there's not as much and not as great as we would like. I mean, the best way to avoid dementia is to die young. So, that's maybe a little too depressing, but it is a very difficult thing to absolutely avoid otherwise. Taking care of yourself well, all that helps. But, to this day, it's my dad's frustration that mom was the healthiest person in the world, had her own garden and did all the things, and it was her only health issue. But sometimes it's just, it's not deserved that way. So we can talk about medications, and there are some times that is applicable and helpful. But it's definitely not a panacea. There's a lot of old school just managing and working around the problem that we have to do still. Other questions?
Good. Yes.
So kind of following up with Jonah, what about like some baselining? Maybe suggest some of that? How does that work?
So like doing memory testing before you have some trouble. Yeah. While I really don't want to get political here, I would point out that President Trump did some memory testing and pointed to that as his "I'm good because I passed this." I can't say I was very impressed with that level of bar for being okay. The memory testing is not really sensitive to really early trouble. The first signs that we're going to see is probably from family members, and you may still test pretty well on the level of testing that we can do. Now, if there's concerns from the family, sometimes what we'll do, maybe to your point, if there's any sort of concerns, is we can take it to another level and do something called neuropsychiatric testing. It's more of a 3-hour kind of more in-depth test. And that can pick up things earlier, and it can also be much more specific about where the problem is, because that can vary from person to person. What part of the brain is affected? Is it visual? Is it verbal? Is it, there's all sorts of different nuances to that, and that can be very helpful in how do you manage your loved one. For mom, verbal went very early. Pictures were helpful, gestures were helpful, but we were taught very early on from her memory testing that explaining stuff to her really isn't going to get through to her very well. Maybe writing stuff out in the beginning, and again, visual verbal stuff was much more helpful. So as far as baseline testing, I don't know that there's a great place for that right now, but have a low threshold to get some basic testing done if you have a concern. Okay.
We have a question
Do you usually recommend seeing a neurologist?
Most of the time, but not all of the time. So this is very patient and specific, but there are times that there's already a lot of other health issues, and there's a lot of most of the medications that we might even consider would have problematic side effects, and they more want what we call a palliative course, in other words, symptom focused rather than trying to look for a cure. And in that case, we may not bring in a neurologist. We would do all the standard testing for the simple fixes. We would talk through options. But sometimes, the specific patients and family members aren't comfortable having too many cooks in the kitchen. I've known them for 20 years. They really want to stick with that, and that's okay. But especially if someone's early on in the disease, or just has concerns about where they might be, it'd have a pretty low threshold for getting them involved, because if there's an opportunity to change the course here, it's best done early. Getting into clinical trials, things like that, are best done early. Margaret, you can speak to that a little bit as well. Most of the time we get a neurologist involved, but not always.
Very good. We have time for one more question before we bring the panel up, and we will have time for some questions afterwards. Anything else for Dr. Coons? Yes, all the way in the back. They're quick.
Would you consider medication if the person is also ADHD?
This is one that hasn't come up much because those ages haven't overlapped much yet, but it's a very good question. I think if they have an underlying diagnosis of ADHD, or we can kind of put the pieces together to establish the timeline. ADHD by definition has to be pretty much a lifelong sort of thing. But if it was always there and not treated, and they kind of pushed through and muddled through, yeah, that's something we might consider. There are some of those medications that have some overlap with depression and kind of apathy issues that can sometimes come up with dementia, and so those medications might be applicable in those situations too.
Well, thank you very much. I thought that was wonderful. Appreciate it. Very good. Well, at this time, we'd like to introduce our panel of speakers, and as I introduce you, you're welcome to come up on the panel. Mark and Margaret Zumdahl are from Sterling. Margaret owned and operated Accents, a gift shop located at Northland Mall, for 15 years. And Mark is a retired attorney, having practiced with Ward, Murray, Pace, and Johnson for many years. As we said before, Margaret was diagnosed with Alzheimer's in 2016, and she and Mark are working as a team to do whatever they can to raise awareness in the community. Also like to introduce Denise Wooden. Denise is a director of CGH Home Nursing. She is a master's prepared nurse, is a certified dementia practitioner, and certified registered nurse infusionist. She's been at CGH for 17 years, but was also director of an assisted living facility before becoming CGH Home Nursing Director. She started her career as a CNA, working for area long-term care facilities. Carla Byrne is a native of Clinton, Iowa. She began her career at Rest Home and Rehabilitation in 2005. She served as the Director of Social Services for 10 years before being named the Director of Marketing in 2015. Carla is extremely passionate when it comes to the residents and families at Rest Haven Services. Jamie Long is the founder and CEO of Golder Care Solutions in Moline. Jamie started Golder Care as a care management and advocacy agency for elder care issues. And as a benefit advocate, he advises clients on their long-term care planning and decisions. He is a former elder care attorney. Wendy Eckel. Wendy is a Whiteside County Senior Center Community Resource Specialist for Aging Disabilities and a SHIP counselor, or State Health Insurance Program counselor. Wendy is the go-to person for Medicare questions and does the New to Medicare workshops at the center. She has a bachelor's degree in health and human service management and was an X-ray technician at CGH for 14 years. She enjoys helping people problem solve and loves hearing all about the past from her clients. And Kristen Fager is care coordinator for Lifescape Services out of Rock Falls. Her role within the agency is to complete choices for care screenings for all of Ogle County and Lee County. She has been with Lifescape Services for 8 months and is currently enrolled at Aurora University, pursuing a Master of Social Work degree with a focus in healthcare. We also were going to have Chris Trotter. You might have seen Chris is the executive director at Sterling Morningside, and she was going to discuss some of the memory care issues, and Chris is unfortunately ill tonight, so cannot make it. But Carl, I understand you're going to pick up some of the slack there on some of those memory care issues, right? Okay, very good. Without further ado, I'm going to introduce, pass the mic to
Sam.
Oh,
Hi.
oh, sorry.
Hi.
Oh, that's what you want. This is what happens when you don't turn the page. Let's try one more time. Hadi Finnerty is the Senior Manager of Education and Community Volunteers for the Alzheimer's Association and a research champion for the Illinois chapter. She tries to educate 5 counties in Illinois. I said tries to educate. This is going to be fun. Strives to educate. It's kind of like tries. Strives to educate 5 counties in Illinois on Alzheimer's disease and other dementias, including warning signs, planning ahead, and promoting brain health. She's affected personally by Alzheimer's, as her grandma was diagnosed in 1999 with dementia. In her current role, Hadi strives to make an impact on families in the community by sharing her own personal experience with Alzheimer's disease. We got everybody on the panel. We're done. Okay. Enough of me. Mark and Margaret.
Do you have is that mic, Barry still there? Okay.
Hello? Hello?
Mine is.
Yeah,
Can
go
you
ahead.
hear me?
Margaret's words.
Yours isn't good?
Well, that's right, we can share.
Yeah, we can share.
No.
All right.
Go ahead.
I'm ready.
Yep, you're on.
Okay, I'm glad to see other people like me. Okay, last time we talked about the steps to obtain. I'm a little slower than I was the last time I did it. I'll start over. Okay. Last time we talked about the steps we took to obtain a definitive diagnosis of Alzheimer's when we noticed changes in my memory. And I'm the worst at night. If you do it at noon, I'm better. This was 6.5 years ago. Tonight, we want to talk about how we decided to live with Alzheimer's. We decided to celebrate what I can still accomplish and enjoy and minimize any losses. Does living with Alzheimer's involve loss? Yes, it does. For example, I can no longer read a book. It's not because I don't understand the words, but I can't remember what happened the page before. The constant frustration of not being able to remember what happened 5 minutes ago without being reminded. Losing my thought in the middle of expressing myself. Fatigue at the end of the day that sometimes brings confusion. So that's kind of how I am right now. Apprehension about the future. There are some of the things we have to cope with. On the other hand, we are grateful for all the wonderful things we still enjoy. For example, driving myself to coffee most Wednesday mornings to spend time with my lifelong girlfriends. Just being with people. I am a social person, and meeting people and talking with them brings joy. We continue to travel and see the beauty of God's creation. We enjoy new places. I take a lot of pictures to bring my memories back. I can't recall on my own. I take pictures all the time. We talk to a therapist every week who's like a friend to keep me uplifted and positive. We spend as much time as we can with kids and grandkids. They love me in a special way, and that keeps my spirits up. We have learned to live in the moment and the present. It is a good way to live. We trust God for our future and live every day the best we can. At the end of each day, we usually say, "Today was a good day."
And I'm going to talk a little bit about our medical journey and talk a little bit about that. As Margaret said, she was diagnosed in April of 2016 with Alzheimer's. She was prescribed the typical medications for an Alzheimer's patient or person with memory issues, and that's Aricept, also called Donepezil. And she then was later prescribed with that memantine, which also goes by the name of Namenda. Now those drugs help eliminate some abnormal brain activity, but it doesn't do anything to intervene in the disease itself. Margaret decided that we didn't want to just sit around and let the disease take over. We wanted to do whatever we could to help in finding treatments or a cure for the disease. So we looked around for a drug trial, and we used the Alzheimer's Association help. It's called Trial Match. And you can put in your information as to where you live, how far you're willing to travel, and then it shows what drug trials are available. And that's exactly what we did. I did a little research ahead of time and determined that there was a drug, it was called aducanumab, that showed promise in a phase 2 trial, and they were starting a phase 3 trial. And so we got accepted into that program in Park Ridge, Illinois. So Margaret started her trial in March of 2017. And that consisted of, there was 18 months where it was placebo. A placebo was a possibility of receiving that. So one group got a low dose of the drug, a second group got a higher dose of the drug, and the third group had a placebo. That went on for 18 months. Every 4 weeks, Margaret would get an injection, not knowing whether it's the placebo or the drug. But after 18 months, and this is somewhat typical, after 18 months, then she was guaranteed that she would receive the drug. Now the drug was targeting the amyloid plaque in her brain, and that's, as you probably know, that's one of the characteristics of an Alzheimer's diagnosis is plaques that develop in the brain that kind of gum up the works, I guess is a good way to say it. So your brain doesn't function like it should. So one of the avenues of trying to develop a treatment or a cure for Alzheimer's was to somehow remove the plaque from your brain that accumulates over time. And so this drug was designed to remove plaque. So she continued from March of 2017 until we got a phone call in March of 2019 where they said, we're stopping the trial. And again, it was just, a phone call. We were scheduled to have an infusion not too long down the road. And they said an independent reviewing team had determined that there was no benefit from the drug and it wasn't worth the potential risk involved. And so because we had been convinced that the drug was helping Margaret stay pretty stable, So our world kind of crashed around us at that point in time, and then we found out, I immediately started to look for another drug trial, but found out that because she was on the one she was disqualified from most other drug trials for at least 1 year. So a year is passing, we're ready to start looking for a new trial. In fact, we had an appointment to get screened for another trial when we get a phone call saying that the trial is now back on because they had reevaluated the data, and it was indicating that, at least for some people, that it was slowing the progression of the disease. So and they invited us back. Anybody that was in the old trial was invited back for what's called an open label trial, which means you are guaranteed to get the drug at the highest dose. So we started back again in October of 2020. There was quite a lengthy period of time, again, because of the COVID situation that delayed the reopening of the trial. And Margaret is still in that trial. So for the last 2 years, she's been getting her infusions every 4 weeks. Now, this is a drug that's been somewhat controversial. It's now called Aduhelm. It was approved by the FDA as a treatment for Alzheimer's. And this was the first new drug since 2003 that was approved by the FDA for Alzheimer's disease. So just think of that, from 2003 to 2021, there hasn't been any drugs that has been approved for Alzheimer's. It's pretty depressing, in all honesty. And this drug was the first disease-modifying treatment. So because Aduhelm was approved by the FDA because it is proven to remove plaque from her brain. So as she's taking the drug, plaque is being removed from her brain. The question then becomes, does that make any difference? So that's where we're at. There's a couple of new drugs coming out that follow the same procedure, trying to remove plaque, that may show that it's even more effective than Margaret's drug. So we're going to keep an eye on that. And there's new avenues that are being pursued different from the plaque angle. So the bottom line here is, if you're facing Alzheimer's, that is an option because there's not a whole lot of other options. That if you're feeling adventuresome and maybe want to help in fighting the disease, is to think about enrolling in a drug trial. There's no cost involved. The drug companies pay for all of the expenses. They pay for our travel, et cetera. So again, I would encourage anyone facing this that may be an option to do that. The other thing I want to mention too is, in fact, I looked at Trial Match today to just see what's out there, and there is a drug called donanemab that shows promise, and now they're recruiting people that have plaque but don't have any cognitive decline. So one of the things that may be coming down the road is you get tested to see if you've got abnormal buildup of plaque, and you receive treatment before you suffer any cognitive decline. And that may be a new avenue or approach to try and defeat the disease.
Mark, could you reiterate one more time on the trial match? It's just on the Alzheimer's Association.
It's on the Alzheimer's website, and I think it's under research. And if you click on the research tab, it'll direct you to trial match, and then you just you input some information. Do you have Alzheimer's? Do you have Lewy bodies? How far are you willing to travel? Do you have a care partner? And then it will show what trials are available. And I think I put within 250 miles of Sterling, and I think there was 56 trials that are available. So now they're not all different. I mean, there may be like 5 locations within the 250 miles that are doing the same test, but there were 55 or 56 different trials.
So you apply and then someone...
Right. You have to be screened because they have different criteria. You have to, be at a certain level, certain age, but you can get screened.
Thank you very much.
Yeah.
Really helps me.
Mark, for a lawyer, you have a remarkable understanding of the medicine of this.
Margaret had the placebo the first 18 months.
I was gonna ask if you were able to figure that out, yeah.
Well, they disclosed that after the trial was terminated. They wouldn't tell you whether she had the high dose or the low dose. So she was only receiving the drug for about 7 months before the trial stopped. But for the last 2 years, she had been receiving the highest dose of the drug. So.
Sure, yeah, question?
I don't have a question. I have a similar experience that Mr. Zondal is talking about. My wife and I have been involved out at Iowa, University of Iowa in Iowa City with the drug trial. We've been involved since 2017. And this particular drug is one that prevents the accumulation of the bad thing in your brain. I can never remember because it's not working. but anyway, in that same light that you just talked about, finding a place for experimental drugs, the lady that we work with has told me that she has 16 different projects going right now that she's looking for people to volunteer to take those, to be involved in those tests. So if anybody's interested in that, see me afterwards and I'll give you the lady's name.
Thank you very much. Any other questions for Mark or Margaret? Denise Wooden is the director of CGH Home Nursing, and Denise, I know when folks are just beginning their battle with dementia, being at home is important. Can you talk just a little bit about in-home care and respite services and how the CGH Home Nursing can help with that? You have your mic? Okay, perfect. Thank you.
Perfect, thank you. Okay, so I am here to talk to you about types of support that are available in the home and a little bit outside of the home. There is the basic day-to-day support, which in bigger communities, there are adult daycares where you treat it just like you would your child. You would take your mother to daycare in the morning and pick her up in the evening. Positive parts of that is it's the same people that work at the daycare, so she gets to know them, she gets a little more comfortable about coming and going. And you know that she is safe and fed and changed, all those things that need to be done. There are some respite services in our area that can be from a day-to-day thing to you want to go visit your sister in London for 2 weeks. So you're able to have somebody that is specially trained and knows everything about the Alzheimer's and about dementia and how to care for that patient and what works and what doesn't work. If you find that you like the facility, then you can do that, use that facility more than once, so then your loved one's a little more comfortable when they come back. I do know a couple of facilities in the area that will even do trials, let you come for the day, check out the facility, see how your loved one interacts with the staff. There is a list of respite providers on your table. It's a pretty wide area, so if you would, maybe your loved one needs to go with your sister that lives in Rockford. There's some caregivers, some options for that area as well. There's also private supervision, so there are private caregivers that are trained in dementia care. You would of course do an interview and decide whether that caregiver is correct for your family member. They can simply just come and stay with your family member for a couple hours where you get groceries, up to 24-hour care, whatever your schedule is that you work out with the private caregiver. Some other things that can be helpful is meal deliveries. We have the basic, Uber Eats, that kind of thing, but there's also meal deliveries that come every day for the patient that can be more towards heart healthy or diabetic healthy if your loved one needs a specific diet, as well as transportation assistance. We have a couple of places in this area that have wheelchair accessible vans that allow you to ride with the caregiver to ride with the loved one so that they're not alone going somewhere. And 24-hour services so that, say, you need to leave the emergency room in the middle of the night, you and your loved one can safely be traveling instead of you trying to get them in and out of the car and that sort of thing. Long-term care in the home, there is private caregivers that we talked about, such as family, friends, or someone that's hired specifically just to care for your loved one. There are also some short-term home care services that can be ordered by your physician. That can include bathing, dressing, eating, ensuring safety. So monitoring the home, do you need a lower bed? Do you need a higher chair? Do you need an alarm for when mom gets up at night? Do you need, like Dr. Kuntz talked about, safety things? Do you need to plug your outlets and put your safety handles on? And maybe switch the way that your door handles lock so your loved one can't lock themselves in somewhere. So those things that can be evaluated and shared with you, that this is how you can make your home safer or your parents' home safer for them. Those types of services are provided by licensed medical professionals and do require physician's order. So that's something that you would want to bring up when you go to see your physician. You know, I'm needing some time, or every time I turn around, mom's getting out the back door, or just express to your physician what you need, and then they can help guide you to which, who can provide that care for you. We do have some residential care in the area, assisted living facilities, to nursing home facilities, and to hospice care facilities. So usually each of those types of places has some dementia care staff. Even if they don't have a dementia care wing, they would have some staff that's specifically trained to provide those cares for your family member. Talked a little bit already about who can help. You can, families, friends, neighbors can work together to share responsibilities. As Dr. Kuntz talked about earlier, it's very difficult to be one-on-one all of the time with a dementia patient. So even if you set up with your sister every Tuesday from 4 to 10, she's gonna come, so you know from 4 to 10 you're free to go. Or your neighbor, maybe it's been your mom's neighbor for 40 years and they're best friends, and she would be more than willing to come and sit with mom for a couple of hours so that you can get out and about. Geriatric care managers, these are professionals who can suggest needed services and help the primary caregiver find these services. This sounds a lot about like what our dementia specialists will be. That's going to be hired through the foundation, so they can help you find the services, help your caregiver find services, help your primary physician find services. Healthcare providers understand the disease and the level of care needed and can offer recommendations on how to meet those needs. So sometimes we wait a little bit because we think mom's just, you know, she's just a little forgetful, she's 75, it's fine, that happens. And by the time that we see the primary caregiver, she's at a moderate or mild stage. So that's where the primary caregiver can jump in and say, these are the things that we need, and the primary care physician or the neurologist, if you're working with one, can tell you how to get those needs met. Social workers, we have social workers in the community, we have social workers within the hospitals and within our local clinics. So if at any time there's something that you need taken care of, they can provide help for you as well as your loved one. We didn't give you the definition of respite care earlier. If you've not heard that term before, it's a temporary institutional care of a sick, elderly, or disabled person, providing relief for their usual caregivers. So it's usually not any longer than a month at a time. if they're going to be institutionalized. If it's something that you've set up in the home with a private caregiver, it could be as long as your parent lives. The home care agencies available in this area that provide specific dementia care. They provide from the skilled care that we talked about, the bathing, teaching you how to feed, that sort of thing, to 24-hour private care. So you could hire a CNA or an LPN or an RN to come and stay in your home with your parent or your parent's home with them, from 1 hour a day to 24 hours a day. We have a couple in our area. We have Gaffey Home Nursing, Castor Home Nursing, Addis Home Care, Help at Home, and In-Home Personal Services. And I just looked at the 5 counties that we cover, so Carroll, Whiteside, Lee, Ogle, and Bureau. Those people travel to those areas and have specifically dementia-trained patient caregivers. Another thing that I was asked to talk about was therapy for dementia patients. Sometimes we think, oh, this patient has dementia. Are they gonna remember how to do the therapy? Are they gonna be strong enough to do the therapy? Are they gonna be cooperative with the therapy? In the home setting and in the outpatient setting, we have some special therapies that are available, speech therapies that can help with memory, cognition, speaking, eating, swallowing abilities. That's something that's lots of times used at the very beginning so that you're taught things that you can do yourself or your caregiver can remind you to do to prevent worsening symptoms. The therapist will help the patient to be able to practice learning information, use written words or pictures, and to remember personal information. So depending on what stage you're in, they can help. I've seen one of our caregivers create a song of the dementia patient's address, so that if she ever got lost, she would sing this song that the speech therapist created that had her address in it. So they're very creative about helping you remember things that might not be something you are having difficulty remembering. They also will train the family members and caregivers with communication tips and feeding tips. So lots of times as dementia progresses, the patient is less and less hungry, or they forget that they need to eat. So the speech therapist will teach the family or caregiver some tips and tricks on, okay, maybe mom will only eat chocolate milk and pancakes. So she'll teach her, okay, I'm gonna teach you how to make protein pancakes, and we're not gonna make mom's chocolate milk with Nesquik anymore, we're gonna make it with Ovaltine, so that she's actually getting what she wants, chocolate milk and pancakes, but she's getting what she needs, protein and nutrients. So they have some tips and tricks like that to help in the home. We also have physical and occupational therapists. Physical therapy is something that can be taught to the patient and to the caregiver, and that is in the intent to keep the patient in the facility or the home that they want to be in as long as possible. So the physical therapist will work on the big muscles, your legs, your back, your core, to keep those strong so that you can walk and you can go and have fun at different places and travel. And then the occupational therapy comes and helps you with the smaller tasks. So buttoning those shirts, bathing yourself, tying your shoes, things that we had to teach our children that sometimes we have to learn to reteach or we have to relearn depending on the situation. So that's just a different aspect of things that can be provided for the patients at home, in assisted living, in total care, in small bits, in 24-hour care. Do you have any questions?
Any questions for Denise? I was curious with the respite care, being a temporary solution, usually no more than a month, I think you said. Does there need to be a period of time that passes between times entering respite care for some benefit resources or otherwise?
Yeah, not as far as I'm aware.
Okay.
Yeah, I'm sure each facility has their own policy.
Sure.
But the most cases that I can think of are in the home when they just need to have a minute, or,
Sure.
you know, I always get my hair done on Thursdays, so I need somebody to come sit with mom while I get my hair done. Or they're going to be gone for a while, they're going to travel themselves and they don't feel like it's safe, or it's, could be more harmful to the person because they can be scared of different environments. So those are the situations that I think of when I think of respite care.
Other questions for Denise? Yeah.
Where can one go to get memory care services specifically for someone still living at home?
So the agencies in our area that provide that, and I will make you a list and bring it to you after. But there are 5: Gaffey, Castor, Addis, Help at Home, and In-Home Personal Services. Now, I don't know where you live, sir, but I only looked in the 5 counties that we cover. So Lee, Ogle, Whiteside, Carroll, Bureau.
Thank you.
You're welcome.
Coincidentally, my daughter also only wants to eat pancakes and chocolate.
Well, I can teach you how to make protein.
Yes. Was there another question? Did I miss one, Jamie?
There was another question.
Oh, was there? Very good. Yes. Run the mic back here to you.
For the respite care, do you know, do they take Medicare, Medicaid, or is it strictly self-pay over and above that?
It is dependent on the facility. The facility that I was the director of, it was self-pay, or they did take some VA benefits. But she'll know a little bit more because she actually does respite care.
Okay, thank you.
Very good. So on that note, great transition, right? Carla is the Director of Social Services at Rest Haven. And so, yeah, lots of different questions about assisted living, skilled nursing care, and facility care. Can you speak a little bit about that? Take us through the different services as we go.
Absolutely. First of all, there is a handout for you. It's blue, and it has all the, it's behind another one that has a bunch of check marks. But the first one is all of the nursing homes, assisted living, skilled care, memory care, facilities in this area. And it also lists what they're able to do for you, what their services are. Later on, I'll tell you, kind of point out exactly which ones are the memory care. And the other one is a checklist on exactly what you might want to look for or ask questions about in a nursing home or any senior facility. You know, anything from how does the facility smell, what's the atmosphere like, what's the food like, gives you all kinds of details that you can ask questions on. However, today I'm going to really focus on dementia care and the whole process. First of all, you need to know what the needs are of your person. Of course, you know a lot of what they already need, but you want to give that information to the facility as well. They need to know what behaviors or what issues your loved one has. You know, are they a wanderer, walking in and around wherever they are? Would they go into other people's rooms? A term I want you to know is elopement risk. If you go to a facility or a home, they always say we talk our own talk. So elopement risk is basically they're exit seeking. They're going to leave. They're going to jump fences like Dr. Kuhn's mom did. But they'll say, is she an elopement risk? We forget to change that terminology. Does noise or a busy environment add to their anxiety and behavior? Do they like to socialize and keep busy? Are they verbally or physically aggressive, paranoid? Do they need oxygen or other medical equipment? All of these factors are important when looking for a place for your person. A lot of homes, whether they're memory care or not, a lot of the homes are equipped and very successful in handling people with dementia in their general population. The home may have a locked unit for safety purposes. They may have a sensory perception room. They may have an area where you can listen to music. They might have a quieter wing. Sensory perception is touching tactile items. We have a veranda at our home that serves for our sensory perception. And there's also all kinds of things that they can look at, touch. It's really great for people that have dementia. The staff at these centers also know how to create activities around the person's needs. They may give them everyday things to do, such as folding towels to keep them busy. We had a resident that she would fold 2 big baskets of towels, and then staff would say, "Thank you so much," and then we'd go to the next room, and she'd want more to do, so we'd dump them out on the table, we'd mess them all up, and then we'd bring them out for her again, and she absolutely loved it. She thought she was participating, and these are some of the tricks that you find that are very helpful. Staff is trained to handle behaviors and to redirect dementia residents before their behaviors escalate, and that can be in the general population of a home, depending on your loved one and their needs. However, if your loved one's behaviors are more aggressive or exit-seeking, or their anxiety gets very high very quickly, you may have more success in a memory care unit where the staff to resident ratio is usually higher. Morningside in Citadel in Sterling, Homestead of Morrison, Liberty Court in Dixon, and Big Meadows in Savannah are the 5 memory care units in this area, and they are listed on that sheet that I pointed out at the very beginning. Memory care units often have lights that are not so bright, therefore adding to a calming effect to the environment for the resident. They may have doors that are harder to see. They may be painted like a bookshelf or blended into the wall so that the exit-seeking resident may not notice that they're there. People with dementia often have depth perception issues. Therefore, what we might see is a pretty pattern on the carpet or floor. People with dementia may struggle walking on it because they see a dark spot on the floor, and they may think it's a hole that they could fall into, or that it's going to be rocky or bumpy and hard to walk on. Dementia residents often eat better if they don't go to a big dining room, so they may be served their meal in their own room. That's more what memory care units do versus general homes. Memory care units take all of this into consideration, and the memory care staff usually have additional training to de-escalate the tougher behaviors quickly. They have 24-hour specialized staff, on-site nursing supervision, and are locked facilities, so know that when you go there, you'll have to push a button, and usually you'll have to wait to be buzzed in and out. And when you go to those units, you've got some really speedy, sneaky people, and some of them don't look as old as you think, and they will follow you out if you are watching, especially Dr. Kuhn's mom, I'm guessing, will.
Hide behind the palm tree.
Oh, they do. They do. They do. Oh, yeah. So it's a really good practice to start looking for a home for your loved one prior to when the need is immediate. You will then be able to take your time selecting where you think your person will best be served. The whole process can be overwhelming. And so if you start early, you can kind of soak it in and think about it and then go back, go to a different home, check things out, find out more information, get educated. I always tell everyone that you're going to want to kind of stop in as a surprise to a home just to see what they're like when you don't have an appointment. Oftentimes it's tricky though because people are pretty busy, and so you might not get as thorough of a tour as if you scheduled it, but you can schedule the tour when you're there, when you pop in. I went to a long-term care meeting this week, and one of the topics we talked about was the increase of people dropping dementia patients off at the hospitals because, for whatever reason, they can no longer care for the person at the home for a multitude of reasons. Maybe the caregiver is sick. Behaviors have escalated, nothing has worked, and people are at wit's end. It's no longer safe. The hospital is not a place for your loved one, and the hospital will tell you that as well. Now, I'm not saying if there's not an emergency, just sit at home. You need to go to the hospital, of course. But in general, it's good practices to start looking ahead of time so you're not caught in that immediate situation. Assisted living homes, nursing homes, memory care units are where your resident will be best cared for and will likely thrive given time. Moving the individual from place to place is hard on them, so it's best to have just one move into a home that has the knowledge and services to help. Often the process to admit someone into a facility may take several days or even up to a week or two. So don't think you're going to call and the next day you're going to get in. It's difficult at times. There are a lot of I's to dot and T's to cross. Your loved one will need to see a physician prior to moving into a home. The nursing home has to have prior directives from a physician before they can have someone come into the home. Someone from an agency called Lifescape, and they are here tonight, will be talking shortly. They'll be giving you, they'll evaluate your loved one to make sure the person meets all requirements for an admission as well. And then the third evaluation is most likely going to be from the home that you have chosen to have your loved one live. They're going to want to come and evaluate to know, to see for themselves how the resident is doing. They'll ask lots of questions, and they want to be able to get prepared for your loved one. Most facilities these days take weekends admissions, which can be very convenient, especially if you're still in the workforce. However, I'm going to discourage you to do that with someone that has dementia. I would encourage you to consider taking a day off during the week. And I've talked to several peers this week, and they say the same thing, because the staffing goes from way up here to down here on the weekends. The new situation, such as moving in, can escalate that anxiety and that behavior for your loved one, and you want to be able to have people there to be able to help. It can trigger a whole new lot of anxiety. You may also see an increase in their confusion when they move. And you can see that for a while until they get used to their surroundings. So don't be surprised, don't get anxious or alarmed if you see your loved one having more increased confusion or anxiousness. This is actually pretty normal for those that have dementia. Make sure to be available to the staff for questions and communicate with them. It takes a team to make this transition go as smooth as possible. Usually the facility will do a life history upon admission. So if someone, say for example, was a night watchman, and they are up all night and they're looking kind of in rooms and walking the halls to make sure there's no bad guys out there. You may not have any idea what they're doing, but if you go back and look at that life story, you're going to see they're a night watchman, and they're going to sleep probably more so during the day because that's what they did for 50 years of life. Some homes may even request you to bring a memory box, and a memory box can be filled with pictures or items that your person is fond of, or that may give them a sense of security or have a calming effect on them. It may include pictures that invoke happy feelings. It may be something your loved one likes to touch or feel. It could be their favorite snack, maybe a magazine with pictures that they like to look at or reminisce about. Even if the home doesn't ask for something like this, you might consider putting it together just because that's then in the home's toolbox for them to say, oh, she wants her blanket, and be able to have it right there. Remember, the staff at the facility are trying to get to know your loved one. They are figuring out the best way to help them feel comfortable, safe, and secure. Don't be afraid to tell staff what has worked for you at home, but don't be surprised if it doesn't work for them either. It may be something else that's going to work for that facility and their staff. Remember to be patient with the whole process. Everyone's learning. They're learning everything that's going on. It's a different situation now. It will take time for your loved one to settle down into their new routine and environment. And they do. We don't really love change as humans, but we do really, after some time, we do fall into it, and we do survive and do well, adapting when we are given time. Okay, for you caregivers, and I think Dr. Coons touched base on this too, taking care of a loved one can be really difficult and very challenging. It can wear a caregiver down without them even realizing it. You need to remember to take care of yourself. In the healthcare business, we often see a decline in our caregivers because they are so giving and they don't take time to take care of themselves. I can do that tomorrow. I'll make an appointment tomorrow. So, if someone asks you if they can help, always say yes. What are you gonna say?
Yes.
Yes. Okay. Sometimes, especially for caregivers, we think we can handle it all and we don't want to bother anyone else. Please let others help. You need that support. We have a couple of great resources that are available to you locally here. We have a great support group. I'm sure they've got information for you on. And the Alzheimer's Association is an amazing resource with tons of educational information and videos on their website. Again, they're here and we'll be talking to you as well. Just a side note, I didn't know what information you had, but there is a service in Clinton, Iowa, where it's kind of a they meet twice a month and they will take your loved one from 10 o'clock until 3 o'clock, and then you can just have time that you want. I know that's a little drive, but if you are in a pinch and you just are really feeling down or it's just overwhelmed, to be able to get out of the house and go watch a movie and have some popcorn or on a day-to-day sit outside and just soak up some vitamin D. I've got that information in the back for you. Joan has it for us. Remember, you and your loved one are individuals. Every journey is different because every individual is different, and every individual that has dementia presents differently. This is a journey, and you need to do what is best for you and your loved one. What may work for someone else may not work for you and your loved one. But you need to do what's best for your loved one, but also for yourself. Don't forget to take care of yourself. Any questions?
Thank you, Carla. Any questions for Carla in the back? Yes. You should just stand in the back. Make it easier.
I don't see the Mount Morris.
Which one's Mount Morris?
Yeah, I mean, I don't see them on here. Are they, do you know anything about them?
Pinecrest and Mount Morris.
Okay. I'm not very familiar with them. Someone from the hospital or down the road here might be more familiar. There's someone here that's a little more familiar with that, so I'll have her touch base on that down the road here. Is that okay?
Yeah, they have
Perfect.
memory care, that's why.
Oh, okay.
Very good.
That's what Old County.
Is it, okay, so it's a little farther away than what I was kind of looking when I put this together from Morrison.
Any other questions for Carla? Thank you very much. Wendy Eckert. Wendy Eckert is the Whiteside County Senior Center Community Resource Specialist, rather. I got that, didn't I? And SHIP Counselor.
Yes.
Wendy, I know that there are a lot of programs in our area that you are likely familiar with your work at the Senior Center that can help some of our community residents. Can you speak a bit to those programs?
Yes. What I did want to tell, when the ladies down there were talking about the respite, our office can do an application for respite funds. They are on a first come, first served basis, and we do accept the ones that are lower income over ones that are with a higher income, but at this time we are we just recently got our funding started for the year, October 1st, so if you call in the near future during open enrollment, be patient with us because we don't only do caregiver and respite things, we also do Medicare, open enrollment, and So just be patient with us, leave, we like voicemails, we do get back with you. We have caregiver assistance, which would be the same, similar to respite. The respite is for, is just for temporary use, it's not for permanent. We had a family that needed to go out of town for a wedding, and so their loved one, we gave them the choice of using the money toward, going to a facility for 48 hours or however many days they needed while they were gonna be gone, or the funding could also be used for 24-hour, or people to work around the clock. So it all depended on, the stress that the individual would be able to tolerate and stuff like that. Let's see. And
There is a brochure on your table.
Oh,
for
yeah.
the senior center.
Sorry. We have a variety of support groups. Vets Coffee, we have a vets get together once a month in our dining area, and they sit around and talk, and one of the ladies that we work with goes down and talks with them and gets some conversation started. And then the Alzheimer's support group, that is, right now, it's partnering with Morningside and CGH Health Foundation, and they get together at Morningside once a month. Let's see. If you have questions on specific times, we do have a lot of our information in the Golden Echo every month. And that is, we have all sorts of areas in our senior center. You can pick up a Golden Echo. If we're not open, we have a little machine outside by door 4. That's just to take an echo. It's not anything you have to pay for. Let's see. And our office is the outreach office, which is Aging and Disabled Resource Center, and we help a lot with applications of all types. Back in September, October, when people were wanting or getting the tax rebate that Pritzker gave out or sent out, there were some people that needed to fill out an application because they didn't file taxes that year, so we helped them with that application. And then at the same time, we were helping people get low cost or free computers, laptops, or desktop style. And that was through the Whiteside County area vocation, well, it used to be vocational center. That's how old I am.
At a career center, right? Whiteside Area Career Center.
Yes. And we help people with the license plate discount that is on an income basis. Household of 2, a married couple would be under $44,533. If you have any questions, you're welcome to call our center, and we'll be glad to answer them. We're all notaries in our office, so if there's anything you need notarized, just give us a call, we'll set up a time. We do have walk-ins if you don't want to really set an appointment for the smaller things. Just come in on a Monday, we'll be glad to help you out. If it's something that's a little more detailed, we would just ask if we could set you an appointment, so. And then we have a food pantry on Thursdays from 1 to 3. That is income-based, but when there's perishable items, at 3 o'clock, anybody can come in and help themselves, so. And let's see. And our lunches are now brought in by Golden Meals, and they're only $3 a person. And everyone I've talked to really likes them. It's very good food. You don't have to have a reservation, although if you know you're coming, you're welcome to call in and let them know. They'll make sure they have enough. At the beginning, when we finally came back to our office and everything after COVID, it took a while for people to get the idea that we were having meals and stuff. And so first couple weeks, there was only like 1 person a day. So yeah, they're doing much better. Oh, and also the $3, they also will accept the link card if you have link card for your meal. We have some ladies come in 2 Wednesdays of the month and do it called Fancy Feet, and they do a pedicure. They if you're going to be a regular to have it done, they like you to bring your own little tub so they can soak your feet and bring your little towel. And I tell you, you feel like walking on a cloud when you walk out of there. I've even had it done, it feels really good. So, and they're very, very careful, very polite, very friendly. And we also, in our office, we deal with a lot of Medicare issues. And from open enrollment, just re-enrolling or checking your Medicare Part D.
But it's so simple and straightforward, right?
Yeah. That's why we're trained twice a year. And I still refer to my books. Yeah, and open enrollment is till December 7th. And don't call the numbers on the TV commercials. They mess people up more than they help. Let's see. We do have, for anyone who has problems hearing on a telephone, we have a special, it's called ITAC. It's for the state of Illinois. You have to be a resident of Illinois. There's no income qualification. And you just need a hearing problem. And then we just ask, we give you an application, and you just have to take it to your family doctor or nurse practitioner or audiologist, someone with a certified, abilities to sign it and certify it, and then we'll show you the phones and we'll let you test them. We have 2 phones that are corded. We have 2 that are cordless. And then we don't have cell phones, but we have a cell phone amplifier, which is very similar size to a phone, but you leave your phone in your purse or your pocket, and then you answer the amplifier.
Oh.
It's nice. It gets a little bit, I'm sure at the beginning, you don't know which one to. We had someone leave their phone at home, and then they called us and said it didn't work. And I'm like, well, the phone has to be with you. So, I know it's hard to, I tell you, I'm, well, as old as I am, it's hard to understand all this modern technology, and I understand how people would think that, so it just kind of gave us a little laugh when we, let's see.
Pretty much covers it.
Yeah, I believe that is.
Very
Any
good.
questions?
Well, several of those programs, I had no idea they existed. Thank you very much.
And there's more information in this, so, if you have any questions, just give our senior center a call.
Any questions for Wendy at all? Very good. Yeah, we can start the clap. Jamie, in your role with Golder Care and being a former attorney and helping being a real advocate for senior citizens in our community, helping us navigate what is obviously a very complex healthcare decisions, particularly as it pertains to some of those costs. How do you, in your role, help advocate for some of these healthcare choices?
Is this on? Is this on?
It is.
It's on? Okay, great. Obviously, what we have to do is we have to look at how the system rules to pay for care intersect with the continuum of care, and that's navigating that system is the primary way that we are able to help people in doing that level of advocacy.
That was like more of a transition into whatever you want to say after that, but I've got follow-up questions I could do.
Well, that does transition right to what we're talking about.
Very good.
I'll address two issues tonight of difficulties with placement, okay? Joan had asked me along the lines that you're talking about here, let's talk about the intersection of the continuum of care and how to pay for care, the financial issues. And that oftentimes leads to issues or difficulties in placement because we may or may not have the funds to do that. There's been another issue that's come up here tonight, and that is what we would call the dumping issue. And we've talked just now about Medicare. And that's a second issue, and I'll bring that up just as well. A little preface to the continuum of care. We've come a long way in the last 100 years or so. As most people in this field, or like most people in this field, I have personal experience with family members who've had dementia. And I'll spare you quite a number of the details, but my family experience with that goes back well over 100 years. My great-great-grandfather was a man by the name of John Blankenfeld, and he lived at Spring Hill, which I'm not certain if it's in Whiteside or Henry County. And back after World War I, he got what is apparently dementia. His daughter, my great-grandmother, a woman by the name of Emma Clavan, had to go to the court in Cambridge, and she had to file insanity proceedings against her father, who she said was no longer basically her father. Today we would call it guardianship, and he was placed in really the first facility, or the only facilities at the time, that dealt with dementia, okay? And that was the East Moline State Hospital. All right, so we've come a long way from the days when we went to the the state facility for the feeble-minded or the mental hospitals. As Carla said, these people don't belong, these situations, we don't belong in hospitals. And in those days, in hospitals and what was nursing homes, we were not residents, we were not patients, we were inmates. So the field has come a long, long way in no small part to the advances in the medical profession and certainly the Alzheimer's Association. So let's talk about that continuum of care. I've got a finger here and a finger here. I don't know if you can hear me. Between those, I want you to imagine a line, okay? That's a continuum. Down here, independent living. Down here, full nursing care. Beyond that is the hospital. But full nursing care. And in between, generally, we have something called assisted living. Okay? That's the landscape that we all face today. Assisted living is about 30 years old as a phenomenon. Some of our old long-term care policies, insurance policies, don't even talk about assisted living because it didn't exist essentially before 1990. When you talk about memory care is, unless you're rendering it at home, or unless you have somebody living fairly independently and going to, say, adult day or something like that, memory care is rendered in assisted living facilities or it is rendered in nursing homes, okay? So a lot of times people will say, he's not in assisted living, he's in memory care. Memory care is either assisted living or it's nursing home, alrighty? Assisted living facilities are not medical facilities, and that makes a huge difference because the primary engine for paying for long-term care in this country is Medicaid, which is a welfare program. And Medicaid starts out as medical assistance. Assistance paying with hospital and doctor, okay? Just like Parts A and Part B of Medicare. But this is Medicaid, it's public assistance. Then there is the form of Medicaid that pays for nursing home care, institutional Medicaid. And then there may be the waiver Medicaid programs. But the difficulties that we often face with our people, and we're talking about counseling them and advocating, come about from what level of care does Janie need? Can I stay independently, or am I beyond the ability to live independently? Well, maybe I don't need full nursing care. In full nursing care, I have to pass, in Illinois, I have to have a sufficient DON score, a determination of need. I have to need assistance with 2 or more activities of daily living, or I need that 24/7 supervision. Maybe I need to be in a nursing home, but maybe I can be in assisted living. We generally want to place people in the least restrictive environment we can, alrighty? And the least expensive. So for the most part, we have a tendency in our system to favor assisted living. But Medicaid doesn't pay for assisted living, all right? Medicaid pays for care in a medical facility, and that is either a hospital or a nursing home. Those are medical facilities. So we have a real issue. We're not going to get into, we can go on for hours about it, but we're not going to get into it. But I want to get into this, I want to get mom into this memory care facility, but it's an assisted living facility and it's all private pay and we can't swing it. And so we're really going for Medicaid and we have to go all the way down to the level of nursing home care. All right, that's a huge issue. We don't have time to get into it in detail tonight, but I want you to be sensitized to that. And that's a real problem in placing people when they don't have the ability to pay privately. Some of the speakers have talked about the need to plan ahead. You want to have enough money on hand so that you can get your loved one placed in a facility when they still have some money to pay for that. You have a better choice, okay? So that's one issue that is the difficulty in placements. And another one we just said is what we would call kind of a dumping issue. And that may be more pejorative than any of us really want or need to be. The difficulty there comes, essentially, and I've lived through this for many, many, many years. The difficulty is that today, Medicare rewards the hospitals and doctors and other medical providers primarily by how much savings they can generate. So the emphasis is not on rendering care, it's on shaving off supposedly unnecessary care or denying care. It's not uncommon for us to see what you're talking about, Carl is describing as kind of a dumping issue. It's not uncommon for us to see that dumping issue all up and down the line, okay? Including, it may start in the hospital setting, sorry to say, okay? We had big difficulties earlier this year. I had many conversations with the Iowa Department of Inspections and Appeals, which deals with hospitals' participation in Medicare. There are something called the conditions of participation, and you have to have adequate discharge planning. One of the difficulties we have with the planning and getting people into the Medicaid beds that they need is that a lot of facilities don't want to take Medicaid pending. So as the message is earlier, let's plan ahead, let's get our ducks in a row so that we can make the transition easy. But when that doesn't happen, guess where we end up placing mom? Mom goes to the emergency room, okay? And that happens with people in the community, that happens with us when we're placing mom. It happens with other facilities when, whether it is assisted living facilities or nursing homes, when we have patients there who are not appropriate, we oftentimes have to wait for the, quote, opportunity to move that person into the hospital setting and then shoot them out the other end through discharge planning. And I've got lots and lots and lots of stories, but that's just one of the realities of the system today. Ironically, today I was speaking with a client. One of our clients is from Britain, and she's thinking of moving over here and getting married to a man and moving here. And they're placing his mother, and we're dealing with some of these issues. And she said, my biggest uncertainty about coming here is your healthcare system. And we don't have the national health service that we do in Britain, which has its problems. But we just said that in America, we have rationing, we just don't acknowledge it and we don't call it that. In Britain, at least, they acknowledge it. With the National Health Service, they have a rationing board, and they have the audacity to call it by an acronym, and that acronym is NICE. It's the National Institute for something like the Quality of Care, or whatever it is, but it's NICE. So there are those two issues that we have with difficulty in placement are how are we going to pay for it, and how are we going to access sometimes a facility that takes Medicaid. Also the VA comes in, but most facilities that's not an issue. And the other issue is if Medicare is limiting some of the services that we can get, we have this dumping issue that has been discussed. Those are both the subjects of their own presentations, but they really get into some very serious advocacy issues, and I'm talking about serious advocacy.
Very good, very informative. Any quick questions for Jamie? Thank you, Jamie. Kristen Fager is care coordinator with Lifescape Services, and I know you're hoping to talk a bit about a program called Comprehensive Care Coordination, is that right? And can you tell us a little bit about that and anything else you'd like to talk about?
I've never used a microphone
before, so.
Is it on?
Like never used a microphone?
Never.
Okay, all right. There we go.
It's my first
Enjoy.
first time speaking in front of the public before, so bear with me. So our community cares program, we work with the Illinois Department on Aging. And because we work through the Illinois Department on Aging, all of our services are free. You do have to be eligible for those services, which usually means going through financials. So you have to be qualified through assets and your income. The best way to go about doing that is just to call into our office, and everyone is kind of like based on individual basis of, there's too many things that go into whether or not you financially qualify for the services or not. Our services are for 60 years of age and older, and the services consist of case management, and then we also do assessments that are determination of a needs score, and that determination of needs score will determine how much your loved one or you yourself qualifies for homemaker services. Those homemaker services consist of, they can assist with personal care, so assist with dressing, grooming, bathing. They cannot lift anything heavy. So if someone were to need a bath aid, for instance, you would have to get a request through your physician to have someone who is more of a registered nurse or a CNA. I'm not really sure who does the bath aids, to be honest with you, but they would have to go through a physician to have a bath aid, but they do help with light housekeeping, laundry, transportation. They're typically Monday through Friday, sometimes on the weekends, and then the hours are typically 7 a.m. to 7 p.m. Now, the one thing with the homemaker services is sometimes you can have a preferred worker, and your preferred worker can be a family member, a friend, a neighbor, and they do have to go through the agencies, the homemaker agencies, to be hired, and then they'd have to do background checks, things like that, fill out an application, and then instead of having a stranger in the home, you would have your family member, a friend, or a neighbor complete those services for you, and they would get paid for those hours that you were being qualified for, those homemaker service hours. Some other things that the services are, you can get set up with an emergency alert button, so it's called EHRS. So those Lifeline, those commercials where you press the button if you fall in, things like that. And then we also can get set up with an automatic medication dispenser. You do have to have a responsible party set those up, and they have visual and verbal reminders. And then some other things that we can do at our office is if there's a financial need, we can help out and get certain things for the home. Our services are designed to keep the participants in their home as long as possible. But some things that we can help out with is assisted devices, getting walkers, shower chairs, benches. And then some other things we've also helped out with when you're talking about a loved one who does have dementia or Alzheimer's is alarms, baby monitors, cameras, things like that, so you can keep an eye on them when you're not home if they're not exit seeking, and then having those alarms for the doors, stuff like that. I have recently interviewed a participant who she did live in her own little apartment, and she has homemaker services, and then her family also keeps an eye on her. They usually will have meals with her at nighttime, things like that. And then at night they usually will go over, get her settled in her pajamas, stuff like that, and then they have the cameras and everything on so that they can keep an eye on her. And then one other thing we also have, so our office does the adult day services, in our Rockford office. So it is a bit of a drive, but we do have the adult day services. And then we also have our home delivered meals program also. So the Lifescape services, the home delivered meals, you might have seen our Lifescape truck around town before. One thing we do cover Whiteside, Carroll, Lee, and Ogle County, so those 4 counties. And then something else that I am familiar with, because this is what I do, is the Choices for Care screenings assessments. Those assessments can be pre-screens, so in the community setting, so in the home, so someone who is needing to be placed in long-term care facility, supportive living services like Heritage Woods here in Sterling, we do those assessments. And then also there's another assessment I'm drawing a blank on. But then we also do the screens at the hospital also. So we'll go to like CGH here, KSB in Dixon, and then Rochelle, the Rochelle Hospital. And those assessments are also, we do those assessments to make sure the person qualifies to go to a long-term care setting. A lot of times we can do education on, we may come in and we do our assessment of their loved one and say, hey, I'm not really sure if this assessment might be appropriate for them. And so we might have our side of it and we talk with them about that, and then we'll talk with the agency that is wanting to be admitted into, things like that. But we have our assessment that we do, and then the admitting facility has their own individual assessment. So our assessment is done through the state to meet a federal regulation through the state stating this person qualifies to be in a facility, whether that be long-term care or supportive living services. I think that's about it, really.
I'll just say, for the first time speaking, a microphone, wonderful, really.
Excellent.
Very good.
I am familiar with most of the Lee-Ogle County facilities. So Mount Morris has Pinecrest, and Pinecrest has an independent living, and then they have their long-term care, and they also have their memory care unit. And then Ogle or Oregon, they have the Oregon Living and Rehab. I believe they have a memory care unit, possibly. But they are a long-term care facility. And then Byron has Generations at Neighbors, and they do have a memory care unit as well. And then Rochelle, there is Liberty Village or Manor Court. I've known it as Manor Court, but some people know it as Liberty Village of Rochelle, and they also have a memory care unit too.
Very good. Any other questions at all for Kristen? Very good, thank you very much.
There is a brochure that has our office number, so if you guys have any questions at all, just feel free to give us a call, and we're there for any type of support, resources, or help that you guys might have. So if something comes up later on, feel free to give us a call. We'd be more than happy to help out.
Thank you. Last but not least, Hot Affinity is with the Alzheimer's Association. We've kind of danced around it quite a bit tonight. Well, I mentioned it several times, but tell us about how the association and what they can do to help.
Sure. Can everybody hear me? Okay. So I'm going to refer to this RAC card. Everybody has it. Just a few of our services I want to highlight is our 24-hour helpline. So this is a free service. It's available around the clock, 365 days a year, and these are helpline specialists or master level clinicians that answer the phone. So they can translate over 200 languages. I didn't even know that there was 200 languages, but there is, and they can transfer. Or excuse me, they can translate. The best thing about the helpline, it helps within those moment needs. So let's say, right now we're getting into sundowning for a lot of individuals. They can help with how to kind of de-escalate some of those situations. They can help with various different things, information, resources. So they're a good tool to have, and you have the number here. We also have early stage and young onset services. So young onset is someone that is diagnosed 65 years or younger. We have tons of different services for these individuals. I had the opportunity to actually be part of our young onset support groups, and they're phenomenal. We also do living with Alzheimer's for people that have young onset, and a lot of the times these people that are in the groups are in their late 40s and early 50s. So a lot of them are still raising their children. Some of their children are graduating high school, going off to college. So phenomenal groups of people that I've met through that. And then our education program. So over COVID, we still do 50% virtual, 50% in the community. But you can find various education programs throughout the community by going to our community resource finder. So alz.org/CRF. You can plug in the zip code and it'll pull the education programs in the community. If you can't make it to an education program in the community, you can visit. We have tons online, anywhere from healthy living for your brain and body to, let's say you're a caregiver and you want to know more about, understanding and responding to dementia-related behaviors. So there's a ton of programming on there. We also have care consultation. So these are individual services. They can be done by phone. They can be done via Zoom or Skype or in person. And these are also, again, with master level clinicians. So sometimes, family members don't all agree. The care consultant will come in and kind of be a moderator for that, or maybe someone got a diagnosis and they have no clue what to do next. They can help talk through that. And then one of my favorite things that we have to offer, which was so beneficial during the 2 years where people could not go anywhere, was our support groups. So right now we do, and I know everyone has them, we have a support group. The third Monday of the month, it meets at Morningside of Sterling. The one thing about here is they do offer respite care. So there is respite care provided for your loved one. There's also one at Mount Morris Senior Center. That's the first Thursday of the month, and that's at 6 p.m. And then everyone will see that there's this support group. The time has changed. So this is Dementia and Alzheimer's Caregiver Support Group, the first and third Thursday of the month at the Riverworks building in Dixon. The new time is 5 to 6:30 p.m. And then Polo Senior Center, the fourth Monday of the month at 2 p.m. also has a support group. We are forming a couple more support groups in Milledgeville and Chadwick Lanark also. So more to come on that. And then, the last resource I want to highlight is ALZ Connected. So ALZ Connected is a free online community for everyone that's affected by Alzheimer's or dementia. This includes people living with the disease, caregivers, family members, friends, individuals who have lost someone Alzheimer's. And this is just an online community. So people go on here, it's kind of like a chat, and they can talk about anything that they want. Or, maybe it's, I just got a diagnosis, I really don't know what to do. Or maybe it's, someone that's, a spouse and they want to kind of talk about how to care for their loved one. Tons of different topics, but this was so beneficial. Again, all you have to do is create an online profile and you can pick I am a caregiver or I'm a person living with dementia, and then it opens up to tons of different chat rooms. And that's it. Thank you.
Thank you very much. Any questions for Heidi at all? Okay, we kept you a little late tonight. I hope everybody was able to take away something from tonight's meeting. This concludes our series. Special thanks to Dr. Coons and the panel. I know several are planning to stick around and answer questions. Before I let you go, very quickly, Joan Hermes, Executive Director of the CGH Foundation, wants to share some news.
We'll let you get going. It was a wonderful night. Thank you, everyone, for coming, and for all of you who have tried to make all three, or just tonight was your first. I think this is a really wonderful resource for our community. And we have two things coming up. I have a bunch of copies of this booklet. It's called 5 Wishes. And you can go through these very personal questions about your future with your family and write it down. The questions are: the person I want to make care decisions for me when I can't, the kind of medical treatment I want or don't want, how comfortable I want to be, how I want people to treat me, what I want my loved ones to know. So the foundation has purchased a bunch of these from the National 5 Wishes organization. They're at my chair here if you want to stop and get one. I think it's a great document to start conversations with your loved ones and to help planning from the beginning to later stages. Another thing, I've talked about this before, we have huge plans. Eric's been helping with this, and Dr. Preeti Joseph and Dr. Chester Dela Cruz. We are going to hire a dementia navigator at the beginning of the year. I'm so excited. So excited. We're still working on funding. If any of you want to make a donation to that, it would be fantastic. We hope to have that person on a part-time basis at the main clinic. So one of the reasons we ask you to leave us with your phone, your email, your address is so we can give you this good news, so we can share and we can explain when this is going to happen. But this person will be assisting our families who are on the dementia journey in trying to locate resources, to educate, just to help make your journey smoother and to show that we've got you. We've got loving arms to put around you and help on this journey. So any questions for me? Yes?
No questions. On the helpline, I called it recently.
On the Alzheimer's Association helpline? Okay.
It's outstanding, and I didn't have to write down all the responses because the counselor sent them to me, email, every question I had and the response.
Awesome.
Good to hear. That's great. That's great. And thank you to the Alzheimer's Association. They've been partnering with us for a year now in getting going on these dementia workshops and other things that we are doing. So thank you all for coming. There is a survey at each of your spots that if you can't give it to us tonight, I would love your responses to be dropped off in the mail, or we will be sending it out in an after email to you. We want to know what you want us to do next as far as education. And one of the gals I talked to today who couldn't come tonight, her suggestion is to have a social activity where you come and bring your loved one and we do bingo or just something to get out in the community and be able to gather with other folks. So ideas like that, events, activities, educational programs, what should we drill down into further that maybe we've touched on with these last 3 workshops? But we'd love to hear from you folks because we want to keep going and helping you on this journey. So thanks so much for coming. Appreciate it.
We all know the, let's go